Yeah, last one is the myxoma. So myxoma versus other mass lesions. So importance of myxoma. The first is that what is the relative incidence of benign heart tumors? If you take the age-wise, the adult 46% is the myxoma in children and infants. But if you go to the malignant tumors, angiosarcoma is the commonest in adults, and infants it is rhabdomyosarcoma, and in children it is mainly the teratoma. So it is a very important thing. So etiology of any cardiac mass can often be determined by considering the 4 factors. What are those? Age of the patient at the time of presentation. As for example, I've given you the importance of the age. Then the epidemiological likelihood and the clinical probability. As for example, a 70-year-old man who recently experienced anterior myocardial infarction with a kinetic left ventricular apex, probability is a clot, not a tumor. Then the location of the tumor, that is another important, that I'll see in the next slide. And last is the non-invasive, now is coming very important, of the multimodality imaging, where is the non-invasive tissue characterization with the CMR. And the importance of the, where is the location, you can see in this chart. I need not to enumerate this. I'll come straight to the myxoma. Because it's a myxoma versus others, so I'll give maximum time to the myxoma. Say this is a classical surgical presentation of myxoma, which we see during the operation table. It's the most common type, mostly common in the 3rd and 6th decade. Females are more than male. It's maybe sporadic, familial, or it may be some with syndrome like Carney's complex, name syndrome, or the Lamb syndrome. It is associated. So I'll give a series of myxoma. First is the commonest, what you see, the left atrial myxoma. So this is a left atrial that you all have seen and all are doing daily. Here is another left atrial myxoma in the transesophageal view. Another left atrial myxoma. This is a huge left atrial myxoma falling onto the mitral valve, and this is how the myxoma looks in 3D. And another picture looking in 3D. This is a right atrial myxoma. And this is the left ventricular myxoma, which is popping into the almost left ventricular outflow tract. And this is biventricular myxoma, both in the left ventricle and the right ventricle. And this is another myxoma abating the left ventricular outflow tract. And this is causing obstruction to the left ventricular outflow tract. This is RVOT myxoma. This is RVOT. This is arising from the RVOT. And this is the last myxoma I'm showing. This is very, very rare. It looks like a right atrial myxoma. But if you go to the, where is the origin, is a septum is free, and this is the right, looking like right atrial myxoma propping into the tricuspid valve. But when you go to the inferior vena cava, it is arising from the inferior vena cava. In the transthoracic, you can see, and we did the transesophageal, it's a huge myxoma coming from the inferior vena cava. Huge myxoma. And you can see the interatrial septum is absolutely free from the attachment. Then is the second common is the lipoma in adult. I don't need not to carry what the lipoma look like. Another importance that I must say is the rhabdomyoma, which is sometimes mimic myxoma-like thing. But rhabdomyoma is strongly associated with some syndrome like tuberous sclerosis, which is an autosomal dominant syndrome. And 78% of the children with symptomatic rhabdomyoma actually died before the age of 1 year. 50% of more rhabdomyomas regress spontaneously after infancy and even resolve completely without the need for any intervention. And this is an adult case. I did it this case, and MRI has been done already, and the patient has been operated. This is a case of left ventricular rhabdomyoma. And you can see, I put the color flow with the low nucleus limit to see whether there is any vascularity is there or not, because I'll show another case of angiosarcoma where there is a high vascularity is there. So here is a very interesting case of rhabdomyoma with Epstein's disease. This is a case of rhabdomyoma with Epstein's. It is a case of Epstein with the rhabdomyoma. This is not very frequent association, but it is said in the literature Epstein can be associated with the rhabdomyoma. This is actually a hemangioma. It sometimes look like abdomyoma, but this is actually a hemangioma. And this is a very vascular tumor, and this is another tumor. Of course, sometimes we have to differentiate certain tumors with the intracardiac thrombi. Like in the left atrial, there is a thrombi sitting in this. There is a saddle septal thrombi. Another thrombus is a ball valve thrombus with the saddle thrombus in the posterior heart valve. You can see the saddle thrombus with the ball valve thrombus. But this is not a thrombus nor a tumor. This is what the SOMIR has showed. This is the huge tricuspid valve vegetation in drug addict. And this is the case of child. In the child, it is basically came as angiosarcoma. It is a highly vascular tumor of angiosarcoma. This is the TB mass in the newborn. And this is a very important thing that now it is coming, is the typical non-invasive tissue characterization of the common cardiac lesions with cardiovascular CMR imaging. And we can stratify the different cardiac tumor with the CMR. And the last two slides is that it is a very important slide to any case of cardiac mass. You follow this flowchart. You cannot recognize with this slide. So I increase the slides. So any cardiac mass, it could be tumor, it could be thrombus, it could be vegetation, or it is structural abnormalities. The probability based on the prevalence. I know it, whether it is a secondary tumor or the primary tumor. If it is a secondary, then identify the primary malignancy, consider the CT, chest, abdomen, pelvis, wherever you want to do. Now, if it is a primary tumor, there is the 90%, we do that, consider what is the patient age. If it is a pediatric population, one subset of tumor. If it is an adult population, another subset of tumor. If it is a primary malignant, then the role of advanced primary or secondary role of advanced cardiac imaging studies, like advanced echocardiography, like 3D, TE, or any other modalities. If this is the most important modality, is the cardiac magnetic resonance imaging, CMR, and you can do even the computed topography and even the PET. So what we have learned from this, echocardiography has evolved since its inception in the mid-1950s, has now become the screening tool of choice for cardiac tumors. Two-dimensional echocardiography is the primary diagnostic imaging modality for the evaluation of the cardiac masses. The judicious use of both echocardiography, CT, and the MRI may be needed in an individual patient for optimal clinical decision-making. Echo technique has inherent advantage as well as limitation that we know, including expense, radiation exposure, image acquisition time, lack of probability. However, 2D is a non-invasive, cost-effective imaging modality that offers real-time, high spatial and temporal resolution imaging from initial evolution of any intercardiac masses. Three-dimensional echocardiography is a useful tool that may provide additional information or better visualization of intercardiac masses. It is conceivable that echocardiography will continue to evolve a prominent role in clinical medicine, that improvement in technology will likely provide better images and diagnostic information in the future. Thank you.